And our next speaker is Dr. Bhagya Veerasingha. She is a consultant ophthalmologist, teaching hospital Anuradhapura. She is going to talk about differential diagnosis of optic neuropathies, a clinician's guide.
Thank you very much, sir. Thank you very much for the opportunity. I'll be taking you through few case scenarios. 18-year-old female girl presented with bilateral reduced vision. Her best corrected visual acuity was 624 in both eyes, and she gave a family history of vision impairment. And this is her fundal appearance. Optic disc shows slightly pale with irregular disc margin with scallop borders. Disc appeared slightly elevated and can see branching pattern of on the disc, branching pattern of vessels on the disc on the superior part of the disc. And the autofluorescence showed hyperfluorescence on the optic nerve head. So this was a case of optic disc drusen in a patient with retinitis pigmentosa. When managing patients with suspected disc edema, it's very important that we rule out causes for pseudopapilledema, like optic disc drusens, elevated crowded appearance associated with hypermetropia. Myopes tend to have an elevated disc nasally most of the time, and tilted disc syndrome, they have elevated disc on the superior part and myelinated nerve fiber layer. Because if we miss a diagnosis of pseudopapilledema, patient will be subjected for unnecessary investigations, lot of referrals, and it's going to be a burden. So first step is to make sure that we are not dealing with a case of pseudopapilledema. Case 2, 25-year-old male presented with blurred vision, right eye visual acuity 6.9, left eye 6.12, and he gave a history of headache and double vision. And fundi showed elevated disc with flame-shaped hemorrhages, dilated tortuous vessels surrounding it, and this was a case of papilledema due to a pituitary macroadenoma. How do you identify true optic nerve swelling? Most of the time it appears hyperemic and can see dilated vasculature, microvasculature capillaries on the disc surface, and more importantly, edematous peripapillary retinal nerve fiber layer. It appears as fluffy, striated appearance, can see obscuration of blood vessels at the optic disc margin, and the presence of flame-shaped hemorrhages, cotton wool spots will lead you to the diagnosis towards true disc edema. Papilledema patients, visual acuity, color vision can be normal at the initial stages, present with transient visual obscurations, grayouts, whiteouts, blackouts, lasting for few seconds, headache, nausea, and vomiting, and also pulsatile tinnitus and diplopia. Another patient, 52-year-old diabetic, presented with sudden onset of visual loss. Right eye visual acuity was 636 with relative afferent pupillary defect, and he had a small crowded disc on the fellow eye. And that was a case of non-arteritic anterior ischemic optic neuropathy. In a patient presenting with more than 50 years with underlying cardiovascular risk factors, with painless sudden onset visual loss, with hyperemic disc edema, it can be sectoral even, in the presence of small crowded disc or disc drusens in the fellow eye, we can suspect non-arteritic anterior ischemic optic neuropathy as our first differential diagnosis. Whereas a patient presenting with much older age, with painful sudden onset vision loss, profound vision loss, like visual acuity more worse than 680, with pallid disc edema, with systemic features of GCA, with inflammatory markers, arteritic, anterior ischemic optic neuropathy would be our first top diagnosis, differential diagnosis. Posterior ischemic optic neuropathy is extremely rare, occur in the context of perioperative period like cardiac and spinal surgeries, acute blood loss, acute hypertension, and giant cell arteritis. They will have signs of optic nerve dysfunction like vision loss, RAPD, but the initial stages optic disc appears normal. Another differential diagnosis for hyperemic disc edema is optic neuritis. A typical optic neuritis occur in young females, and vision loss would be gradual over several hours or days, and they complain of periorbital pain. Uh, 2/3 of typical optic neuritis is retrobulbar in origin, so optic disc appears normal, and the pathology would be multiple sclerosis. And in a male patient, male gender with age more than 50, with bilateral vision loss, with disc swelling and persistent visual loss, with lack of recovery in 1 month time, we can consider atypical optic neuritis as our differential diagnosis. And the pathologies would be neuromyelitis optica spectrum disorder, MOC antibody disorders, can be post-viral or post-vaccination. Another patient, 36-year-old male, diabetic for 12 years, presented with blurred vision. Visual acuity was 6/6 in both eyes. Color vision was normal, and no history of headache, and his MRI brain was normal. And this was a case of diabetic papillopathy. In diabetic papillopathy, most of the time they are asymptomatic and can see visual functions are normal and can see marked dilatation of vessels on the disc surface. And this disc edema can last for a few months. It's like a persisting disc edema. Another patient, 52-year-old female, presented with headache, reduced visual acuity left eye for 1 year duration. Disc appeared slightly elevated with pale appearance, and MRI showed optic nerve meningioma. Another 32-year-old male presented with hand movement vision in the right eye and left eye 660, and he had very high intraocular pressure with advanced cupping in both eyes, and this was a case of glaucoma. When talking about optic neuropathies, always present with signs of optic nerve dysfunction, reduced visual acuity, affected fields, disc chromatopsia, RAPD. Disc can be normal in the initial stage if the involvement is retrobulbar, swollen disc, and pale disc towards the end. So etiologies would be increased intracranial pressure, inflammatory causes, vascular causes, compressive causes, hereditary causes, toxic nutritional deficiencies, trauma, and glaucoma. So when we are making a diagnosis or determining the underlying cause, we have to take these factors into consideration: age, the onset. If it is a ischemic pathology, would be a sudden onset visual loss. If it is an inflammatory pathology, can be progressing over hours or days. And the laterality, presence of pain. Non-arthritic ischemic optic neuropathy would be painless, and while arthritic will be painful, as well as optic neuritis also will present with pain. And color vision, type of visual field defects, optic nerve appearance and results of neuroimaging, all these factors need to be considered when we are determining the underlying cause of optic neuropathies. Thank you.
Thank you, Bhagya. You have elaborated nicely there how to differentiate from AIONs from other conditions by giving your own case files.